So this is the section portion of Chapter 8 entitled The Physiology of Dynamic Left Ventricular Output During Passive Mechanical Ventilation. It's a bit of a mouthful, but it's worded very specifically because this is what we are, this is exactly what we're doing when we are looking at systolic pressure variation or pulse pressure variation or stroke volume variation. This dynamic left ventricular output, as I mentioned, there's multiple ways to do it. In addition to pulse pressure and systolic pressure variation, which are surrogates, you can directly measure stroke volume variation. You can look at plethysmographic changes in pulse contour. You can look at arterial pulse contour analysis as a surrogate for stroke volume variation. They're all different ways of essentially doing the same thing, and that is seeing how the left ventricle responds to a given cardiovascular stress, which is, in this situation, a change in intrathoracic pressure. So what is the genesis of these dynamic changes in left ventricular output? Well, it's actually induced by changes in right ventricular output just a few beats before you see the changes in the left ventricular output. So the low pressure right ventricle is very sensitive to changes in preload. So a good way to induce a change in preload is to raise your intrathoracic pressure. And as we saw in the first portion of this chapter, that if you raise the intrathoracic pressure, the right heart cardiac function curve shifts relative to the systemic venous return curve, and you have a reduction in preload as a function of the increase in intrathoracic pressure. Another way you can do it is you can actually increase preload by, say, giving the patient a fluid challenge or doing passive leg raising. But what we're going to talk about in these first sections is stroke volume variation and its response to changes in intrathoracic pressure. So the gradient for the entirety of venous return, remember venous return, that is the blood returning to the heart, has to equal the blood leaving the heart. So the blood returning to the right heart is equal to the blood leaving the left heart. So the entirety for all of venous return returning to the right heart is very small. It's only 10 millimeters of mercury. So very small changes in intrathoracic pressure will impart really large changes in venous return and therefore cardiac output. As we saw in the first section, Part A, an increase in intrathoracic pressure preload reduces the right heart by shifting the cardiac function curve relative to the venous return curve. If the venous return curve is intersecting the cardiac function curve on the cardiac function curve steep portion, the patient will be volume responsive. That is, increasing the venous return curve or increasing preload will result in sorry, I'm getting a bit tongue-tied. If the venous return curve intersects the right heart on its steep or volume responsive portion, then as it's shifted rightwards in response to the increase in intrathoracic pressure, there will be a significant reduction in right heart output. And then 2 to 3 heartbeats later, essentially the pulmonary transit time, the reduced right heart output will have traversed the pulmonary vascular bed. And if the left ventricle is also operating on its steep portion, that is the volume responsive portion, then the reduced RV output will translate into a reduced LV output, and you will see LV output variation, a change in your systolic pressure, a change in your pulse pressure, which we're going to talk about in quite a bit of detail. So again, this is mechanical inspiration and RV output. So this curve is the right heart function curve here. This is your systemic venous return curve here. Blood flow or venous return or cardiac output is on the y-axis. On the x-axis is your right atrial pressure in millimeters of mercury. So this is your intravascular right atrial pressure here, or your CVP here, and this is your cardiac output in response to this, and this is called the operating point of the cardiovascular system. So again, this applies to patients who are fully adapted with the ventilator, which induces an inspiratory increase in intrathoracic pressure. If the patient's also generating inspiratory negative intrathoracic pressure, then it's going to severely confound this physiology. So in the patient who's heavily sedated and potentially paralyzed, the x-intercept of the cardiovascular or the cardiac function curve represents your intrathoracic pressure. So this is your intrathoracic pressure. at FRC or at end expiration, the patient's intrathoracic pressure is slightly subatmospheric. Again, this the y-axis here intersects the x-axis at 0, so this is atmospheric pressure. All of this is above atmospheric pressure. All of this is below atmospheric pressure. So with the mechanical ventilation, the increase in intrathoracic pressure shifts the cardiac function curve rightwards relative to the systemic venous return curve. You have a decrement in your cardiac output from here to here, okay? And that is a good indicator that the cardiac function curve is intersecting on its steep or ascending portion. By contrast, if the patient is on the plateau or the volume non-responsive portion of their curve, the same increase in intrathoracic pressure from a mechanical breath will induce essentially no change in cardiac output. And this patient will be deemed to be volume non-responsive. Okay, so this diagram simplifies things a little bit because, as you probably recall from chapters 3 and 4, that the act of inspiration, whether it's spontaneous or mechanical, actually induces changes in the venous return curve. It tends to actually shift the venous return curve rightwards a little bit, and it may actually even increase the resistance to venous return. And actually, the increase in lung volume that you get with an increasing transpulmonary pressure, again, whether that's spontaneously induced or mechanically induced, tends to afterload the RV a little bit and may shift the cardiac function curve down into the right a little bit. So there's the active inspiration not only shifts the cardiac function curve rightwards in parallel to the systemic venous return curve, the active inspiration actually modifies the venous return curve itself a little and the cardiac function curve itself a little. But I've left that out here just for simplicity and illustrative purposes. So let's talk about systolic pressure versus pulse pressure variation. So if you were to have an apneic baseline at the end of a long expiratory pause, this is your A-line tracing essentially. This is your systolic pressure, this is your diastolic pressure, this is your dicrotic notch. So the systolic pressure at the end of an expiratory pause becomes your baseline, and this is your reference for changes in your systolic pressure and pulse pressure. So the systolic pressure max is up here, and that's relative to the baseline. Your systolic pressure minimum is actually down here relative to the baseline. Again, it's come down throughout a single ventilatory breath. And this difference here is called your D up or delta up. And similarly, this is called your D down or delta down, this difference here. And what I've indicated here is kind of a generic airway pressure tracing, and then you can see that really by the end of inspiration is typically when you have your maximum systolic pressure, and that your minimum systolic pressure is occurring during expiration. And you can probably already guess, or maybe you already know, that the reason that the drop in systolic pressure is occurring during expiration is because this is the pulmonary transit time. So during inspiration, you're having that reduction in right ventricular output, and then a few beats later, that decreased right ventricular output hits the left ventricle and then is reflected in the arterial pressure tracing during expiration. Okay. In terms of pulse pressure, the pulse pressure, as you know, is the difference between your systolic pressure and your diastolic pressure. So the maximum pulse pressure occurs typically during your systolic pressure maximum, and your pulse pressure minimum occurs during your systolic pressure minimum here. So you can see the difference between here and here is the pulse pressure max. The difference between here and here is your pulse pressure min. Okay, and pulse pressure variation is actually this value plus this value divided by the average of the two multiplied by 100%. Okay, and what I want to emphasize here is that even though I've depicted in airway pressure, in conjunction with the change in the arterial pressure tracing, it is not the airway pressure per se that's driving these physiologic changes. Just because these are on the same graph together doesn't mean that one is driving the other. The airway pressure is indirectly driving these physiologic changes, but remember, it's kind of a few steps away. So airway pressure has to increase lung volume. Lung volume will increase based on pulmonary compliance, and then the degree to which the lung volume increases and then pushes out against the chest wall will determine your intrathoracic or pleural pressure change. And again, that's itself going to be dependent on chest wall compliance. So it's the airway pressure change is a few physiologic steps removed from the actual driving force of the systolic pressure variation. Okay. So peak systolic pressure and arterial pulse pressure are directly related to left ventricular stroke volume. These are used as surrogates of beat-to-beat left ventricular stroke volume. It's argued that the D down or delta down is a more specific indicator of RV preload responsiveness, as it is the D down that as we saw, occurs during expiration, which reflects the delayed and diminished RV output that occurred during inspiration. Despite that, clinical investigation typically measures systolic pressure variation than D down per se, and systolic pressure variation is simply just the difference between the systolic pressure max and the systolic pressure min. So investigations have shown actually that pulse pressure variation is superior to purely systolic pressure variation as a marker of volume responsiveness, and it may be partially because the systolic pressure variation while it's taking into consideration D down, it's also taking into consideration D up, which is probably a little bit less specific in terms of predicting volume responsiveness, and the reason for that we'll get into in a few slides. And that's what I just mentioned here. Systolic pressure variation, that is SP max minus SP min, is less sensitive and specific marker of fluid responsiveness than pulse pressure variation, which is that pulse pressure max plus the pulse pressure min divided by the average of the two. Sorry, I said that wrong. Pulse pressure variation is the pulse pressure maximum less the pulse pressure minimum divided by the average of the two. I'm going to get angry letters from my mother. It's reasoned that because changes in intrathoracic pressure can directly alter arterial pulse pressure, that the pulse pressure will more truly reflect LV output than that's a typo, than simply following systolic pressure max and min. So there's a direct, this is work I think out of Pinsky's lab that was in chest in the late 90s, that some of the pulse pressure variation that you see from a mechanically delivered breath, some of the increase, the D up and D down, is simply a reflection of transmitted intrathoracic pressure directly to the aorta. And so if you're just looking at systolic pressure max and systolic pressure min, some of that may be driven by direct transmission of intrathoracic pressure to the aorta. But if you look at pulse pressure, because the systolic and diastolic pressures should be equally effective by the change in intrathoracic pressure, that looking at pulse pressure rather than systolic pressure per se will wash away some of that measurement artifact. And indeed, that's what's been found. So let's look at stroke volume and arterial pressure. So this is your arterial elastance curve. You can see it's curvilinear, and the shape and slope of this curve will change with age. As you get older, that your central aortic elastance gets much higher. That is, its compliance decreases, and vice versa when you're young. And similarly, infusions of vasoactive medicines will change this as well. You can imagine giving nipride will significantly decrease the elastance of your aorta or increase its compliance, and will change the relationship between the aortic blood volume and systolic pressure variation. So the volume in the central arteries that end diastole reflects the central diastolic blood pressure as a function of arterial elastance. So if this is your aortic blood volume at end diastole, this will be your this systolic pressure. This should say aortic pressure. This would be your diastolic pressure and the diastolic volume. And then as blood is ejected into the aorta, the volume within the aorta increases, and so too does the systolic pressure. So this is your end diastolic blood volume in the aorta. You get a stroke volume from the left ventricle. You've increased your aortic blood volume, and now your aortic pressure, sorry for the typo, your aortic pressure has increased up to here. And so this difference here is your pulse pressure, your difference between your systolic pressure and your diastolic pressure. And so you can see that there'll be a direct relationship between your pulse pressure and your stroke volume. And it's modulated by your left ventricular, your aortic elastance curve. So clearly a maximal systolic pressure, so up here, and pulse pressure are related to stroke volume, as I just mentioned. Central arterial elastics does not change significantly over the course of a few cardiac cycles, which is what you see when you're measuring the change in pulse pressure or systolic pressure to a mechanical breath. So this does not, the changes in central arterial elastance should not contribute to changes in the blood pressure. But you must bear in mind that infusions of vasoactive substances such as nipriate and Levophed have been shown to alter this relationship. And there's a whole body of literature actually on looking, it's kind of interesting, I'm unfortunately not going to include it in this chapter, but looking at the change in pulse pressure to this change in stroke volume. So you're looking at your pulse pressure variation over your stroke volume variation and using that as a marker of central arterial elastance. If you're able to measure pulse pressure and stroke volume on a beat-to-beat basis, you can then derive measurements of central arterial elastance, and you can use that to predict whether or not patients may need a vasodilator or a vasopressor as a means of augmenting blood pressure. So left ventricular output, there's multiple ways to measure the beat-to-beat LV output. I think I've mentioned this in a few slides. The surrogates previously described, such as just the peak and minimum systolic pressure variation, the pulse pressure variation. You can look at plethysmographic changes like in an oximeter, arterial pulse contour analysis. There's more direct measures such as aortic outflow tract velocity time integrals, which you can measure by a transthoracic or transesophageal Doppler probe. And there's specific esophageal Doppler measurements of descending aortic flow that can be used. Whichever method is utilized, however, the principle is essentially the same. That is, large changes in left ventricular stroke volume in response to a mechanical ventilation-induced intrathoracic pressure elevation should reflect biventricular preload responsiveness. So what are the specifics of this physiology? Well, we've talked a little bit about the basics already, but let's talk about some of the mechanisms here. So, this is the pressure tracing we saw on the previous slide. This is your apneic baseline that we talked about. This is your DEP. This is your maximal systolic pressure, maximal pulse pressure. So what are the mechanisms of DEP particularly? Well, there's quite a few. As I mentioned, there can be this direct transmission of intrathoracic pressure. That is, as you give a positive pressure breath, the pressure within the thorax increases, and this is just simply directly transmitted to the aorta, which will be reflected as an increase in your blood pressure. There's also a decreased afterload effect, as we talked about in Chapter 3 and Chapter 4. That is, you increase the intrathoracic pressure, you increase the pleural pericardial pressure around the LV. That increase in the blood pressure on the outside of the LV actually lowers your left ventricular wall stress, which facilitates unloading of the left ventricle. During inspiration, you get improved left ventricular compliance, and that is the result of favorable diastolic interaction. That is, during a positive pressure breath, the preload to the right heart decreases, so right ventricular volumes tends to be diminished, and as you shrink right ventricular volume, you improve the filling characteristics of the left ventricle. And then additionally, increased pulmonary venous return, which occurs in response to the increase in transpulmonary pressure that you get. And that is a function of how much West Zone 3 territory you have in your lungs. So you can sort of think, as the volume of the lungs go up during inspiration, the pulmonary capacitance beds, particularly the alveolar capacitance beds, is diminished, and that tends to squeeze blood out of the lungs and favor pulmonary venous blood flow. And the more West Zone 3 you have, the greater this effect will be. And so the reason that I've put it in red is that really this is, out of all of these mechanisms of D-up, or your increase in systolic pressure during inspiration, this is really the only one that has anything to do with volume responsiveness, or volume per se in general. And the increase in pulmonary venous return that you have, because it's a function of West Zone 3 physiology, you can actually see that in overload state. So this could be a mechanism of a false positive, but it may also reflect the previous expiratory increase in pulmonary blood volume, because during expiration, during mechanical expiration, I should say, the right ventricle is actually being preloaded. Remember, during inspiration, the right ventricle shrinks, its preload is reduced. Then during expiration, the right ventricle is actually accepting blood. And then during expiration, the right ventricle is actually charging the pulmonary vascular bed with blood. Also during expiration, the right ventricular afterload tends to decrease. So there's two things going forward, going for the right ventricle during expiration. It's being volume loaded, and it's got a lower afterload. So during expiration, it's actually charging the pulmonary vascular bed with blood, and then during inspiration, that blood in the pulmonary vascular bed is then discharged into the left ventricle. So that's a portion of your D-up too. I think one of the more classic papers that describe this physiology was written by Jourdain and colleagues, maybe in 1983 in Circulation, I think, and they kind of describe it as a piston-like effect of the mechanical ventilator, sort of squeezing blood into the left ventricle during inspiration, and then during expiration, charging the pulmonary vascular bed with blood as the right ventricle loads the lungs. So these are the four key mechanisms of your D-up, or the increase in systolic pressure, or your increase in pulse pressure. And again, just to reiterate, I've said this before, it's not the airway pressure that's directly driving these changes. It's changes in intrathoracic pressure that are driving all of these changes, not the airway pressure per se. So let's look at the mechanism of D-up in terms of our friend Guyton here. So right ventricular function curve, left ventricular function curve. This is systemic venous return. This is pulmonary venous return. Okay, right atrial pressure, left atrial pressure. Again, this represents 0 or atmospheric pressure, as does this here. So an increase in intrathoracic pressure lowers the left ventricular afterload somewhat, but in a normal heart, this effect is fairly trivial. So this effect is much more important when somebody is in heart failure. So the decrease in afterload tends to shift the left ventricular function curve up and to the left just a touch, which means that for any given filling pressure, you have more flow, more blood flow leaving the left ventricle. Okay, but So that's during inspiration, the increase in intrathoracic pressure. Simultaneously, the increase in intrathoracic pressure shrinks the RV cavity as a result of the decreasing transmural pressure. So in the right heart, because the systemic venous return is extrathoracic, most of it's in the abdomen. 75% of your venous return comes from your abdomen through your IVC. And because it's extrathoracic, you're increasing the pressure in the thorax relative to systemic venous return. So you actually shift the right heart function curve relative to systemic venous return curve, which you do not see in the left heart. Remember, pulmonary venous return from the pulmonary veins and the left heart are all within the thorax. So they actually shift in unison, so they don't shift relative to each other. So during inspiration, you shrink the right ventricular cavity as right ventricular preload is reduced, and that improves left ventricular compliance. So you can sort of think of that as shifting the LV function curve up just a little bit more. And in the normal heart, this is probably less of an important mechanism, but certainly prominent, more prominent, I should say, than the afterload effect. Okay, and then what happens? Well, as I mentioned, the increase in lung volume, as you increase your transpulmonary pressure, increases your pulmonary venous return as a function of West Zone 3. So the greater the percentage of your lung is in West Zone 3, the greater this increase in pulmonary venous return effect will be. So in that situation, you actually do shift pulmonary venous return relative to the cardiac function curve as transpulmonary pressure increases. So you can see that during a passive mechanical breath, that the left ventricle has multiple physiologic phenomenon moving in its favor. You're decreasing its afterload, you're increasing its compliance, and you're actually increasing its preload as blood is squeezed out of the lung. So you've actually increased your left ventricular output from A to B. We just saw that shifting effect. It's going from here to here, and all this is occurring during a single inspiration. So that changes your delta up. And again, some of that D up is also just from direct intrathoracic pressure transmission to the central aorta. Okay, so what about D down? Well, we've talked a bit about D down already. Let's just go over systolic pressure variation one more time. Here's your apneic baseline. This is your systolic pressure min. And the difference between your minimal systolic pressure and the apneic baseline, this determines your D down. And as I mentioned, many argue, in particular Sheldon Magder argued that the D down is a better physiologic parameter of volume responsiveness, because it's this D down that's really reflecting that diminished RV preload that occurred during inspiration. And the initial papers on systolic pressure variation actually looked at systolic pressure variation and D down, and found that a D down as little as 5 millimeters of mercury was, I believe this was dog data initially, that a drop in your systolic pressure below an apneic baseline of as little as 5 millimeters of mercury was very sensitive and specific for predicting volume responsiveness. And so the mechanisms of the D down are somewhat kind of the converse of the mechanisms of D up, which we just talked about. So there could be a direct transmission effect. So again, positive pressure breath during inspiration, the intrathoracic pressure is going up, and then clearly during expiration it's going down. So you'll have just a diminution of your intrathoracic pressure as being part of it. There'll be an increased left ventricular afterload as the intrathoracic pressure is coming down, but that's probably a minor effect in a normal heart. There'll be a diminished left ventricular compliance as the RV is being charged with increased venous return during mechanical expiration. So the right heart will fill and then impair LV filling capacity. And then there's also probably the most important effect is the diminished venous return. So this is the reflection of the impaired inspiratory RV output that occurred 2 to 3 cardiac cycles before inspiration, because that's the pulmonary transit time. So this is the delayed effect During inspiration, the RV is shrinking, the RV output is going down, and then that's during inspiration. 2 to 3 cardiac cycles later, as that diminished output traverses the pulmonary vascular bed, you then see that reflected in the D down during expiration. Again, for reiteration, the airway pressure is not the primary determinant of these changes. It is intrathoracic pressure that is driving these changes. And in the passive mechanically ventilated patient, the change in intrathoracic pressure is directly related to your tidal volume of the lungs, and that is related to pulmonary compliance. And it is related to the chest wall compliance. It's inversely related to the chest wall compliance. So the mechanism of D down, which is occurring during expiration, you have to think of sort of what happened during the inspiration. And remember, the increase in intrathoracic pressure shifts the right heart function curve relative to systemic venous return, and you have this diminished RV output during inspiration, which is then 2 to 3 cardiac cycles reflected as your D down during expiration. So again, this line here, as I've indicated in previous lectures, this is your transmural pressure or distending pressure of the right atrium and right ventricle, and you can see that at end expiration it's fairly large, and it's the difference between your intraluminal right atrial pressure, or CVP, and your intrathoracic pressure. And then with the positive pressure breath, intrathoracic pressure increases, your right atrial pressure also increases, but not as much as the increase in intrathoracic pressure, and therefore your distending pressure or transluminal pressure, transmural pressure decreases, and therefore the volume tends to decrease. Simultaneously, your cardiac output from the right heart during inspiration goes down. 2 to 3 heartbeats later, during expiration, this is reflected as reduced pulmonary venous return. So this is your LV function curve, which is now operating up here following the previous inspiration that we just talked about. Okay, so then you have this drop in your pulmonary venous return from here during peak inspiration to here during expiration, and this will contribute the greatest to your D down, or the drop in the LV output. And similarly, the decrease in intrathoracic pressure during expiration distends the RV, which impairs LV compliance by ventricular interdependence, and also mildly elevates the left ventricular afterload, and that's occurring during expiration. So again, during expiration, the RV distends, right? Sorry, going in the wrong direction here. During expiration now, the RV distends from there to there. Okay, the transmural pressure of the RV is increasing during expiration, which then impinges upon left ventricular compliance. So your left ventricular compliance shifts down a little bit. Your afterload is increased, so it shifts your left ventricular cardiac function curve down a little bit more, and that, coupled with the decreased pulmonary venous return, results in a significant D down. If you were to then allow this patient to reach their apneic or end expiratory baseline again, your pulmonary venous return curve would shift out to here. And so you can sort of think of this pulmonary venous return curve as your end expiratory pulmonary venous return curve, and this drop in pulmonary venous return relative to the end expiratory value was the result of the previous inspiration. So again, this is the mechanism of the D down, and it's primarily, which occurs during expiration, and it's primarily driven by the diminished RV output that occurred during the previous inspiratory event. So the previous slide illustrated the basic mechanism of left ventricular stroke volume variation. I've oversimplified them, believe it or not, to some extent. because, as I mentioned previously, that the venous return curve changes with changes in lung volume, which I talk about more in Chapter 3 and Chapter 4. And further, the right ventricle is typically afterloaded with inspiration, so as you inspire, the right ventricular cardiac function curve may actually shift down into the right a little bit. And the diagrams all were under zero PEEP conditions, or ZEEP as it's called. But I left that out just for simplicity, and we'll talk a little bit later about how PEEP can affect these parameters as well. But the key principle is that the inspiratory increase in intrathoracic pressure is utilized to assess for biventricular volume responsiveness. So that was the second part of Chapter 8. That was the basic physiology of systolic pressure variation and pulse pressure variation in the fully passive, mechanically ventilated patient. And again, these changes in D up and D down were all initially derived, and their excellent sensitivity and specificity for predicting volume responsiveness were all derived in this group of patients who are not generating any spontaneous breathing effects. So that's why we had to analyze it under those conditions. So in the next couple of sections, we'll talk about some of the caveats for using left ventricular output as a marker of fluid responsiveness in the mechanically ventilated patient, and how it can break down in certain states, like when a patient is spontaneously breathing, or when there's ARDS or pulmonary hypertension. There's a lot of, as the literature has been coming out in the last few years, there's a lot of caveats to using pulse pressure variation and stroke volume variation as markers of fluid responsiveness, which I'll get into in subsequent portions of this chapter.